Hi guys, today's topic about superior semicircular canal dehiscence is an osseous defect of acute eminence of the petrous temporal bone. First reported in 1998 by Miner and colleagues. The fluid in the membranous superior canal can be displaced by sound and pressure stimuli, creating certain vestibular and auditory signs and symptoms like Hearing its hearing symptom of autophony, hyperacusis, pulsatile tinnitus, and hearing loss. On mainly low frequency hearing loss or conductive hearing loss is seen. Vestibular symptom like vertigo and imbalance can be seen because of this third window phenomena. These changes are increased by Valsalva maneuver or any pressure changes in external auditory canal leading to vertigo or giddiness and sometimes oscillopsia. There is nystagmus on eye on sound. It's suggestive of superior semicircular canal dehiscence. Pathogenesis is average thickness of bone between the superior semicircular canal and middle cranial fossa at birth is about 1.1 mm, which increases 1 mm in the adulthood. So thickness is about 1 mm. Dehiscence in adulthood seem to be related to lack of development of this bone and perhaps weakening of tough dura so that pressure can be transmitted between the labyrinthine and middle cranial fossa. So this acts as a third window in labyrinthine. Third window lowers the total impedance of inner ear, ability to withstand the oscillating forces from outside. Short episode of vertigo can occur as a result of increased intracranial pressure associated with cough, nose blowing, toilet straining, and any pressure changes. This can trigger a brief feeling of rotation vertigo, involuntary eye movement, nystagmus, and same can effect can be caused by increased middle ear pressure or Valsalva maneuver. So this any pressure changes through third window phenomena can lead to nystagmus, oscillopsia, autophony, vertigo. These are classical symptoms leading to this. There is diagnostic criteria like autophony. There is at least one A to D should be fulfilled, like vertigo, oscillopsia, pressure changes, and pulsatile tinnitus. B criteria is at least one of the following is there: nystagmus, low frequency, negative bone conduction hearing loss, or enhanced vestibular evoked myogenic potential, response on affected side, or CBAMP and OBAMP amplitude, or classically seen in high resolution HRCT. There is defect in the arcuate eminence and superior part of the semicircular canal, or it should be ruled out by MRI or CT scan. There is no other associated pathology which leading to vertigo. So these A to D criteria should be fulfilled, and these symptoms like autophony, oscillopsia, pressure change, pulsatile tinnitus, these are the classical presentation. Diagnosis mainly computed tomography, BAMP, and PTA low frequency hearing loss is more than sufficient. This is mainly clinical diagnosis supported by BAMP and computed tomography. So in HRCT, Stenner's view or coronal view, you can see properly there is defect in the tegmen. And Fiesta MRI is also helpful, which is almost equivalent to computed tomography to diagnose the superior semicircular canal dehiscence in middle cranial fossa. You can see there is defect in the CT scan, the arcuate eminence in superior semicircular canal. Sometimes you required MRI Fiesta to rule out other pathology and diagnose properly with supported by CT. This is the superior semicircular canal dehiscence. You can see this picture, both MRI and CT scan showing the defect in the tegmen and arcuate eminence of the superior semicircular canal. So mainly clinical and CT scan is more than sufficient to diagnose. You don't require any BAMP or PTA testing to diagnose this, but they are supportive. You can add the pure tone audiometry as well as the BAMP testing, so that it is confirmed that you are facing the superior semicircular canal patient. DD may be patulous eustachian tube, Meniere's disease, benign paroxysmal postural vertigo, cervicogenic dizziness, and persistent postural perceptual dizziness. The treatment mainly, the middle cranial fascia approach is simplest approach, standard surgical approach to repair the superior semicircular canal dehiscence syndrome. It can be done by endoscopic, transmuscular, transcranial, or transcanal approach. All these surgeries are same and result are same. So basic classical surgery is middle cranial fossa approach, that is straightforward approach to doing the superior semicircular canal dehiscence. And nowadays it is done by 2 centimeter craniotomy only. The most common surgical repair for superior semicircular canal include plugging the dehiscence. Middle cranial fascia plugging close the dehiscence. The procedure can be plugged by fascia or fat. You can plug the dehiscence. You can plug the dehiscence by transmuscular approach also, and it's routinely done surgery also. You can approach by this approach also, but best is simple is transcranial approach. And resurfacing, this repair technique covers the opening without closing it completely. It is less common than plugging, so you can do any one and all results are the same. You do plugging or resurfacing the dehiscence. So these are the surgery available for superior semicircular canal dehiscence, but mild to moderate symptoms don't require any surgery. You have to counsel the patient and prevent from loud sound and any pressure changes which increase the vertigo. So this is all about superior semicircular canal dehiscence. Thank you so much.